She is Associate Professor in Department of Pharmacy, BITS Pilani, Hyderabad campus. She has completed her B.Pharm and M.Pharm from Jadavpur University, Kolkata, and PhD from Department of Pharmaceutical Sciences, Wayne State University, Detroit, Michigan. And she was as postdoctoral fellow for 1 year from Wayne State University and postdoctoral research associate in Northeastern University from 2009 to 2013. And she is in BITS Pilani, Hyderabad from 2013. Dr. Swati has published more than 75 articles in peer-reviewed journals. She has 10 patents, 5 book chapters, and 2 monographs. And she presented so many conferences. And she is recognized among the world's top 2% scientists in the single year 2019 in pharmacology and pharmacy or nanoscience and nanotechnology or clinical medicine. Citation: Leonardis J.P.A. Boyack K.W. Bus J. 2020. Updated science-wide author database of standardized citation indicators. So, thank you, Dr. Swati Biswas, for coming to this session. And I heartily welcome you to our FDP program in JIS University. Thank you, madam.
Thank you.
Yeah, it's over to you.
Okay. Thank you, Devjani, for introduction. So let me share my screen. So I think my screen is shared.
Yes, ma'am.
Yes, yes.
Okay, thank you. Okay. So it's a great honor and privilege for me to speak our research in front of you, and I'm greatly thankful to JISU University for inviting me, and of course Dr. Maji, and I know them very well for so long. And it's so nice to see you all. And yeah, it's great feeling. And even though it's virtually, but I think we can have the same kind of, feeling that we are together and listening to something from me. So it's a great feeling for me. Okay, so today, actually, I'm going to talk about the polymeric nanomedicines in cancer therapy, and we'll discuss about some opportunities and challenges. So without much delay, I can start going to the main discussion. So I would say that it's for a long time, 1.5 hours, and it is difficult to concentrate on one topic or listening from one speaker for that long. So if you have any queries, you can probably use the chat box, or you can also talk and we can discuss. So I'm open for any of the discussions related to these PowerPoint slides that I'm presenting. So if there is anything that you need further clarifications, please go ahead and ask me the questions. Thank you. Okay, so yeah, so this is all about cancer. So to give a brief introduction about that, when I started working on cancer is like in 2009, when I joined the laboratory of Professor Vladimir Torchilin, who is very well-known scientist in the field of cancer nanomedicine, and I started working in his lab. And before that, my PhD was in Parkinson's disease, but then I picked it up, and these nanomedicines became like a bread and butter for me to think about it for every day. And that's what I have been doing for last around 12 years or so. Even more than that. So yeah, so cancer is the abnormal proliferation of cells. So every one of us know that all of a sudden that one of our cells start behaving abnormally. Now, what is that abnormality that happens to a normal, so-called normal cell? So it happens that there is some DNA that gives us the signal that something went wrong. So there will be some upregulations of the proteins, or there will be some downregulations of the proteins. So the upregulations of the proteins which are helpful to have the cells undergo apoptosis, so those things are highly suppressed. So we can say that the like P53, which is a very friendly protein for our body, because it helps the cells to undergo a programmed cell death that is called the apoptosis. But in cancer cells, they are majorly downregulated. And if we see that what is happening to the other side, like what are the things that are getting upregulated, so we see that there are anti-apoptotic proteins, which like BCL2, for example, for surviving, they gets upregulated to a very high extent. Now, what is happening? That is basically so much of research going on about that why all of a sudden it happens. But it happens when a body ages, so it is not possible to cope up with all these functionality running in a better way. So that can happen to these abnormal situations, and body's immune system also do not work properly to get that eliminated, get that abnormal cell eliminated from the body. So, but then when it starts replicating, there are so many upregulations that happens and so many downregulations that we observe. Right now coming to definitely that as the cells grow, so we know that there are many stages that it goes through: stage 1, 2, 3, and 4. And then if the stage 1 or 2 it's not invasive, but stage 3 and 4, it starts going to the nearby lymph nodes and goes and metastasizes or makes their home in other parts of the body. So this is what actually happening, and then then it is very difficult to cure. So it is like my research is on the advanced development of the advanced nanomedicines. So I will go to that, but before that, let me talk about a little bit about the hallmarks of cancer. So this is a well-known there's a well-known review which came it's long back, 2011, and that is basically it came actually before that, but anyone working in cancer has definitely referred to this paper. It came out in Cell, and it talks about all the hallmarks of cancer. And this professor Weinberg is in Harvard Medical School, and then they have come up with very nice thorough observation throughout whatever happened till 2011, that how this happened. But after that, the next generation of this review has not come yet, but hopefully it will come soon. So this basically tells about that there will be the cancer cells will sustain the proliferative signals. What does it mean? That it will keep on proliferating, and without knowing that it has to stop at some point. So these proliferative signals are so high in there. And then also another thing that goes on side by side is they evade the growth suppression. So there is nothing that can control the growth. There is nothing that can suppress it. So it goes proliferate abnormally. Now, then it also avoids the immune destruction. As I says that whenever something abnormal happens to our body, then it just the immune destruction kills that. But for this particular body, then that kind of immune destruction happens. And then also another thing, that enabling replicative immortality. So cancer cells develop immortality. If we think about a normal cell, and then it doesn't replicate for a long time. There is like only 5 to 6 times replication, but then it goes to senescence, and then it don't grow anymore. It undergoes apoptosis. But cancer cells can grow for a long time, like enormously, for enormous time of cycles it can grow. So then there is the inflammation which actually comes surrounding it. There is a tumor associated macrophages. The tumor associated macrophages are very deadly, I will say that enemy for the tumors, because it helps in growing the tumors. And then all these things happen that it resists the cell death, and then a lot of mutations are happening. So all these things will make the cancer proliferation. Now there are so many treatment strategies are around, but surgery and radiation is still considered the gold standards in the treatments of cancer. And of course, thus before and after the surgery and radiation, the chemotherapy is kind of supplemented, so that when the surgery has to be done, then the tumor should be smaller. And when the radiation, before radiation, in order to make the tumor smaller, the adjuvant therapy is done with the chemotherapy in majority of the cases. So in case of, like here, I briefly highlighted about the different treatment strategies, and then definitely radiation, immunotherapy, hormones, stem cells, and targeted therapies are available. But I will say that the chemotherapies are still in the very nascent stage of development, because whichever we see in the clinic that has like the doses or the medicines that are being applied, they are combination of 2 or 3 anti-cancer drugs, but still they are given conventionally. And we've also noticed that there are so many different side effects of that. And so in order to reduce the side effects, in order to make the chemotherapeutic drug more effective, we need to have a better way of formulation, of formulating the system, formulating the anti-cancer drugs. And that's where the nanomedicines play a very unique role. Now, what basically that we look for when we prepare the nanomedicines is that how they are targeting to the cancer cells. So it is basically like a Trojan horse approach that usually it is called like that. So it is something like that the cancer cells will not know that this like it has been taken out, and then it basically kills it, because these cells are basically very smart, and then they develop the resistance for the drug also. So that is another challenge that with the conventional therapy, and that is basically the one major limitation in cancer, in chemotherapy, because the development of multiple drug resistance actually causes the ineffectivity, not only makes the chemotherapeutic drug ineffective, but also it actually causes the cancer cells very stubborn, and it happens that there is no other drugs that can suppress the growth of it after some time. So that's what is the failure of the chemotherapy. Now, but we already know that some of the drugs are so effective in the in vitro and in vivo preclinical models. Like if we think about the doxorubicin or paclitaxel, they have shown their potency and effectivity in all different phases, but all majorly preclinically and in the experimental models, animal models, they have found very high effectivity. But so far, if you see in the clinic, only the liposomal formulation of doxorubicin, which is available as the nanomedicine. So it seems that we are actually in in 2021, still we don't have a lot of these anti-cancer drugs as nanomedicine available. Of course, there are paclitaxel, another drug which recently came out as Abraxane, which is albumin-bound nanopaclitaxel, but only these two drugs which are usually being used and effectivity. Now, if you think about that, what are the different nanocarriers used for the drug delivery systems? Then there are liposomes, there are polymeric micelles or polymeric nanoparticles, there are dendrimers, and there are some of the inorganic nanoparticles as well. Okay, so liposomes are there for a long time. So it actually developed in 1960s. And from there, it came all the way it took almost like 30 to 40 years. And then it came into around 2000, it came in the market as the doxil, the first doxorubicin loaded liposomal formulation. But then after that, we probably know that the Sun Pharma's Lipodox came out, and after a long battle of making it the generic version of it. And what basically it does, it actually substantially decreases the cardiotoxicity of doxorubicin. Doxorubicin is a hydrophobic drug which is made hydrophilic by making the hydrochloric acid salt, because it has a basic amine group. But then what happens that when this drug is administered in our body, it has a preferential accumulation for the cardiac myocytes. So it actually causes the cardiac damage. And then that is the major reason that this drug cannot be taken for longer time, because it actually has the risk of the risk of heart attack. So that's the reason that this is conventional therapy is not effective at all. But on the contrary, the liposomal formulation reduced the cardiotoxicity drastically. And then we also found out that there is another formulation that is available as paclitaxel, but the paclitaxel is another a different composition where human serum albumin is used as the vehicle to carry the paclitaxel to the blood. So what happens that this actually forms the vesicle size of around 100 nanometers, and then they eventually accumulate in the tumor environment. So which is that is the reason that this, and also if we compare what is available conventionally, then we see that we have the Taxol. Taxol, what is the composition? It actually using a harmful chemical as surfactant, which is chemophore-EL, and that chemophore-EL actually is highly toxic, and it causes so much of allergic reaction to the body that the patient needs to be hospitalized before administration of the conventional drug Taxol, and then they have to be hospitalized and they have to be on a anti-allergic treatment before the Taxol is administered, because it has so much of side effects. Now, after this human serum albumin bound nanoparticle came into picture, this kind of anaphylactic shock or this kind of allergic reactions became negligible. So these two drugs have shown the promise of nanomedicines or promise of nanoparticle mediated drug delivery systems in cancer therapy. And now I can also say that, is it only cancer, or there are some other, other diseases that can also be affected? So you can see that wherever there are some abnormalities in the blood vessels, you can find that this nanomedicinal strategy is going to be effective, like myocardial infarction or inflammation, like arthritic conditions or inflammations. So these kind of systems that the blood vessels are swelled, there are leakages in the blood vessels. So nanoparticles find its way to go to that microenvironment and can release the drug slowly in sustained manner. So that's where is the beauty of using the nanocarrier. So it can be used for many different disease conditions for sustaining the delivery of the drug. But for cancer, there are some unique thing, and that's why the the next generation cancer therapy will only rely on nanocarriers. No conventional therapy should be applied later on. But till now, that has not happened. Now, if you see that why the nanomedicines get targeted to cancer, there are two ways that it goes. If probably many of you know about this active and passive targeting. So passive targeting is a phenomena which came into 1995 by a famous scientist from Japan. His name is Maeda. So he came with the concept that, and they have proven it in the animal model, that if they give some fluorescently labeled nanocarriers and they find that it actually goes to the tumor. Now, why is it happening? Then they kind of analyzed, and they have seen that these tumors, when they grow abnormally in a high rate of proliferation, then what happens that these blood vessels won't they cannot cope up with that high rate of proliferation in the cancer cells. They are mutating, of course, but these cancer cells, these endothelial cells, they just can't cope up, so they make something like abnormal blood vessels. That the blood vessels are not normal, they are not so structured. So you can see in this figure that if you see that this like the one which is at top, the cells are very much organized. This is the blood vessel, and you can see that the blood stream, and this is like, you can see the top part of this blood vessel is very much organized. The cells are very much organized. But when you go to the vicinity of the tumor, you can see that there are some leakages. There are some leakages in the endothelial cells, and that actually gives the permission for the nanoparticles to get internalized in the tumor microenvironment. But that also happens eventually. Not everything will come at a time and can enter. It actually, the chance of their entrance gets, enhanced when there will be long circulation of the nanoparticles in the system or in the body. Okay, so if that happens, so the long circulating nanoparticles get eventually accumulated to the tumor microenvironment. So that's what is the first approach or first strategy for the nanocarriers for the tumor targeting. So this is known as the passive targeting. Now we also have another targeting option, which we call as the active targeting. Now, what is active targeting? Basically, the active targeting uses the ligands which are on the surface of the cells, right? On the surface of the on the nanoparticle. So how we select the ligands? The ligands are basically selected based on the upregulation of the tumor cell-associated receptors. Now, as an example, I can say that the tumor cells, they are proliferating so rapidly that they have a lot of demand for iron. So what will they do for that? They actually develop a lot of transferrin receptors on the surface. Now, we also see the overexpression of transferrin receptors in liver, because the liver actually needs a lot of iron to process. So there is overexpression of transferrin receptors in the liver, but there are some of the tumors which actually overexpresses these transferrin receptors, and majorly, like most of the tumors cells overexpress, but there are certain type of diseases like hepatic cancers, they actually have high level of expression of the transferrin receptors. Now, if we modify our nanoparticles with transferrin on the surface, then definitely, while it will be having a long circulation in the bloodstream, it will go and it will eventually accumulate via active targeting. So transferrin is one of them, but there are so many other ligands also scientists have worked on. So there are like folic acid receptors, because the rapidly growing cells need the folic acid to make their DNAs, because folic acid is required as a cofactor. So they actually need to produce their DNAs. So they need a lot of this folic acid. So folic acid receptors are also overexpressed, if you see, compared to the other normal cells. Okay, so we always have to do the comparison with the normal cells, because the normal cells don't express any of those in a higher proportions. Okay, so this is one of them. Third is the biotin. Biotin has a lot of biotin receptors are overexpressed in cancer cells because they need a lot of biotin. So it is not just that. We already know, if you think about certain cancers, like let's say that breast cancer has some of the breast cancers have overexpression of HER2, which is the epidermal growth factor. They also have overexpressed in the estrogen receptors. They have overexpression progesterone receptors. So if we have certain kind of antibody, now antibody mediated targeting can also have a strong affinity. So we can have the anti-HER2 antibody tagged nanoparticles. So definitely it will go to the HER2 positive breast cancer cells. But one thing is here that you have to remember, that there are certain breast cancers we do not express those. So we have definitely in order to make the treatment effective, we have to find the diagnosis to be strong, because if the diagnosis is not strong and it comes to a level that the drug cannot do anything, then the whole point of making the systems, it won't work in that way, right? So diagnosis also needs to be improved, and these are the things that are also used, and nanoparticles are also used for the diagnosis by using this kind of approaches of active and passive targeting. So if you see that the trend of application submitted to CDER for this nanomedicines, you will see that there is it's keep on increasing. Like if you see that there were very few of the came out, then after that it is basically so many nano formulations are coming into the clinic, coming into the clinical trials, and so many applications are submitted for this nanomedicines. Now here, as I said, that we will discuss about something new about the polymeric nanomedicines. The reason I wanted to discuss about the polymers, because so far what we have in the clinics, those two are, if you think about that, one liposome, which is made out of lipids, and we already know that there is the phosphatidylcholine, which is the main component, and along with that cholesterol is there, and a very small proportion of polyethylene glycol phosphatidylethanol has been added in the liposomes. Now, why this polyethylene glycol phosphatidylethanol is added? Just to give the long circulation in the liposomes, because if that is not present there, then it is difficult to make them long circulating, because that is considered as a naked liposome, and the naked liposomes are taken up by the cancer cells. So this will not not taken up by the cancer cell, it will be taken up by the reticuloendothelial systems of our body. So when we inject that, then the body immune system will start working, and then they will engulf that, and we take it to the liver or kidney, and from there the elimination will happen. So this is not possible with that. Okay, so that is the reason that a small proportion of the polymer PEG has been attached to the polyethylene glycol. Now, the question is that why the PEG has been attached to the polyethylene glycol? Why the PEG has been attached to the lipid? Why we can't use only the PEG as a coating? So actually the lipid, if you see the liposomes, it's a bilayer structure. So something has to be anchored. Otherwise, it won't stay. So the polyethylene glycol is highly hydrophilic. Now, if we take that highly hydrophilic material, it won't going to get attached to the liposome. So we need some anchoring device, and then that phosphatidyl ethanol is added as the anchoring device. So these kind of materials are always amphiphilic. So it has the, like, whichever is used for the coating of the nanoparticles. Now, polyethylene glycol is a gold standard in all these coatings wherever we need to prepare the nanoparticles long circulating. So that's the main thing that we always look for, where we can make the polymeric systems with having polyethylene glycol and also the amphiphility. So that's the main thing. So we, when we talk about the, and also as I said that this is the liposomes, the doxil is the liposomal formulation, and human serum albumin formulation is the paclitaxel. Now, when we see that, then human serum albumin is body's main transporter protein, and the main, you can say that the abundance of the human serum albumin is highest in our body as a protein. So human serum albumin, then when human serum albumin is mixed with paclitaxel, and then they undergo the emulsion is high pressure, homogenized under high pressure, then they form the small droplets, and what happens that this paclitaxel actually goes into the grooves and crevices of this big 66 kilodalton human serum albumin and makes it form a vesicle structure. So there is nothing else, nothing is there, no other excipients, nothing. So that's the wonder of that how these two found the matching or found the proper amalgamation to form the nanoparticles, which actually protects, not only protects the paclitaxel for easy liberation or off-target liberation, but it also helps to dissolve paclitaxel, because paclitaxel, another difficulty of using paclitaxel is that it is highly hydrophobic, and that is the reason, in order to dissolve it in the conventional preparation Taxol, we are using 50% of that cremophore EL, which is a very which is a non-ionic surfactant, but because we are using so high proportion of it along with the ethanol and other components, we are using so high proportion of it that basically it starts making the body toxic, like it makes it causes saponification in the cells, and all the anaphylactic reaction starts. So now that we don't have anything in the market with the polymeric systems as the nanomedicine. So what in our lab, what we basically do is mostly work on many different polymeric systems. Now, as one type of system that we really intrigued with is the polymeric micelles. Polymeric micelles are made up of amphiphilic polymers. As I said that we always need to have polyethylene glycol as the hydrophilic moiety, and we also need the we also need another polymeric system, which is the hydrophobic system. So hydrophilic and hydrophobic, if we keep together, then it forms the amphiphilic polymer. So now, if the amphiphilic polymers, we keep some hydrophobic drugs along with it, or we stir it, then we find that in water they self-assemble. Now, when they self-assemble, they form the core, and in the core, the drugs, hydrophobic drugs, get attached. But unlike liposomes, it cannot take the hydrophilic drugs in the core because it doesn't have the aqueous core it doesn't have the aqueous core. But the polymeric micelles are more effective in loading the hydrophobic drugs, because if you see the liposomal structure, only the lipid bilayer can hold the hydrophobic drugs, and which is not a huge compartment. But in case of polymeric micelles, we can actually increase the length of the hydrophobic polymer, and we can get the drugs incorporated in that area. So which is the added advantage with the polymeric micelles. Another reason we also favor the polymeric micelles are the inexpensiveness of the polymers, because it's all made these majorly they are synthetically prepared, unlike lipids or unlike the human serum albumin. So if we think about the lipids, then this has to the processing of that to get a reasonable scale is a little bit challenging, and also there are some stability issues with the lipids. But then if you think about the human serum albumin, it also has to undergo so much of processes, and we have and then it has to be obtained in a pure form. So unlike that, the polymers are easily available and we can use that, and if we can get the same kind of benefits, then of course the polymeric systems will be much advantageous to use or to store or to scale up, or for any other reasons it will be very much useful. So as I said that there will be two things: hydrophilic corona and hydrophobic cores. So what are the polymers we can use for that? There are multiple polymers that can be used to make the hydrophilic corona. Is the polyethylene glycol, as I was mentioning to you, and also the chitosanes, that hyaluronic acid. So this can also be used. Now, if you see about the chitosanes will have a lot of amine groups. We can see that it's a polysaccharide, and what is the good thing? It is naturally available, and after cellulose, this is the second most abundant natural polymer, and so if that chitosan, and it's highly hydrophilic also, and so we can use that to prepare the hydrophilic corona, and then we will also need the core to form, and in order to form the core, we need to use the some of these hydrophobic polymers. So there are synthetic polymers, and also we can use the lipids and combine the lipids. So polyethylene glycol can be combined to lipids. We get the PEG-DOP, PEG-DSP, like that structure, or even PEG cholesterols. This kind of systems can be prepared, even though they are not natural, but we can synthetically prepare those. And then also polylactic acid, polycaprolactone, polystyrene, and so many other acrylate polymers can also be used. And in order to lipids, so definitely phospholipids, fatty acids, sphingolipids, steroid molecules like cholesterols can also be used for that. So in our studies, we used the PEG-PLA as the polymeric micelles to prepare the polymeric micelles. So PEG, I already told you, and here I have shown you that we can use the polylactic acid to prepare the amphiphilic polymer. Now, if we prepare if we conjugate those two, then we can get the amphiphilic polymer. Now, what basically the advantage it will give, we can increase the solubility. Now, if you see that the curcumin is a model drug, model anti-cancer drug. Why it is a model anti-cancer drug? Because it hasn't come to the clinic yet. But if you see so many preclinical studies are done on curcumin, and most of them, because it's highly hydrophobic, and the and so all the other nano medicines formulations that I'm describing can incorporate this curcumin very well. And this, with these active and passive targeting approaches, it can go to the tumor environment very easily, owing to the active and passive targeting phenomena. Now, solubilization, also it improves the solubilization. So with nanomedicine formulations, we will increase the solubilization, we will increase the biodistribution, we will make them specifically go to tumor in higher amount compared to the conventional therapy. And also we can avoid the PGP expression. So what is that? Basically, that, as I said, that if we treat the tumor cells with a low dose of a drug, doxorubicin or any other anti-cancer drugs, then after some treatments, we will find that they upregulate the resistant markers. So P-glycoprotein or para-glycoprotein is one of the markers that the tumor cells express when it is undergone a reasonable time with the low dose of a drug. Okay, and exactly the same thing happens in the systemic circulation. Like when we administer this conventional therapy, the drug cannot reach in optimal concentration to kill the cancer cells. So what happens that it can kill the initially the upper part of the highly proliferating cells, but then the inside, which is highly necrotic, I will say, and which has a very low concentration of oxygen, and so all these things actually upregulates all the resistant markers. Now, what these resistant markers do, they simply, when the drug enters, they simply allows the drug to efflux out. So these are known as the efflux transporters. So they just efflux the drug out, and so they undergo the mechanism to how to efflux the drug out. Now, but if we use the nanomedicines, it has been found that this kind of thing doesn't work, because we are giving the drugs in a vesicle form, right? Now the vesicle goes to lysosome, and from lysosome it bursts and it liberates the drug. And when it liberates the drug, by the time the drug reaches the core of the cells, it doesn't, and the efflux transporters are basically in the surrounding the cell membrane, like on the cell membrane. So whenever the drug enters, it goes out. But in our case, like when we use the nanomedicines, it goes all the way from inside the cell, because it goes through the process of endocytosis. So it goes to the early endosome, then late endosome, then goes to the lysosome, and from there it liberates. So that's why it is long passage, and so it doesn't have really much interaction with the cell membrane associated transporters, and that is the reason that this is more active, and it is not basically helping to develop the generation or help to generate the multiple drug resistance. So this is advantageous in that regard as well. Okay, so now coming to how did we formulate the PEG-PLA. Basically, the synthesis of that PEG-PLA polymer was done by the ring opening polymerization reaction. So what we did, actually, we have the MPEG and we use the DL lactide, and DL lactide, basically, if we use a polymerization condition, and in this case we have used the stannous octoate as a catalyst, and the toluene was the solvent, and we increase the temperature to around 160 degrees centigrade, 120 also it works, and then it forms the PEG-PLA. without further modification, we use the polymer by dialysis technique, and we got the product, and then we lyophilized the product, and we got the fluffy solid powder as our polymer. Now we have the curcumin in methanol, and we have the PEG-PLA in chloroform, and we used these two as a rotary evaporation to remove the solvent, and we got a lipid film there. And then if we rehydrate it at PBS 7.4, and then after that, then we get that the yellow colored solution, and it is basically solution. There is nothing precipitates. When we work with the liposomes, we see that it is a colloidal solution. You can see that some colloids are there, even though it is not precipitating because of their size. Like I would say that the liposome size goes around 100 nanometers or even more than that. But these liposomes, this micelle size comes less than 50 nanometer, or at the most it forms 100, but it doesn't go beyond that as well. So usually we find it around 50 to 100 nanometers, even less than that. So that's why you will see it is always a clear solution, and which is also beneficial compared to liposomes, I will say, because when the if you think about that EPR effect, which I discussed, that leaky vasculature mediated drug delivery, which is known as enhanced permeability and retention effect. But if that kind of thing happens, then it basically depends on the leakiness of the vasculature, and then the leakiness basically, if there is a little hole, not so much, then the micelles can go because of their size, but then liposomes will not be able to. So it says that the nanoparticles need to be the size less than the 200 nanometers to get the benefit of the enhanced permeability and retention effect. So here I will say that these polymeric micelles have the advantage of being nano size, very small size compared to even the liposomes. So now, and then after centrifugation at 13,500 G, we find that these things are precipitating out because it's a high RPM, so it precipitates out everything, and then that we actually we can lyophilize and get the solid powder. So as I say here, the liposomes, the lyophilization of liposomes are difficult because this is after reconstitutions, everything changes. It is not, so that's why reconstitutions are not really much possible. But here polymeric micelles are very stable, so it can be lyophilized without any problem, and we can reconstitute and can achieve the same particle size as before. So we did some of these structural characterizations. So when we prepare the polymer, so the things that we have to do is we have to analyze this polymer, and we have to see that whether they are prepared correctly or not. And after, so in order to do that, the first characterization that we do is the proton NMRs, and we see that whether all the peaks of that are present or not. So there will be definitely this methoxy pre-peak, which will be very prominent. So we find out that whether that peak is available there or not, and these CH3 peaks are also present or not. So with that we conclude, and even the PEG gives the CH2, this PEG gives a very prominent huge peak in the NMR, and that is the indication that the polyethylene glycol is present. We also do then after that, when you prepare the drug loaded micelles, then the major characteristic study that we do is the measurement of the particle size. So then we found out that these particles are like, this is forming the very around 100 nanometers with the 9.5 to 1.5 curcumin, PEG-PLA and curcumin ratios, and then drug loading and entrapment efficiencies are also measured, and this has been found that this is optimum. So what we do basically, then we select. So the selection is done based on the drug to polymer ratios. Now we cannot make, so each, like when we use the drug to polymer ratios, we see it varies the amount of drug that is taken for the incorporation, of course, along with the amount of polymers that are needed. So now the entrapment efficiencies are always high. There is nothing like we can think about if it is above 90, this is good. It always depends on the interactions of the drug and the polymer. So sometimes if the drug is too hydrophobic, they will really love to stay in the hydrophobic core. So then we get the high entrapment efficiencies. But if for some drugs, there are some polar groups present, which doesn't allow it to go completely in the core, then we get not so good entrapment efficiency and also the drug loading. So now so then this one, we actually characterize the polymer, I mean the micelles, PEG-PLA micelles, and also the curcumin PEG-PLA micelles by transmission electron microscopy and also by the Malvern zetasizer. And then we also found then another study that is very relevant to perform here is to find out the critical micelle concentration. What is critical micelle concentration? That we are actually preparing this amphiphilic polymer in the lab. So we need to see that this amphiphilic polymer, what concentration they are forming the aggregates. Now, in order to do that, we found the critical micelle concentrations, and we actually compared that with a standard PEG-DSPE polymer. So PEG-DSPE, it's commercially available. So we have taken that into account, and we have seen that our polymer is that PEG-PLA is also self-assembling to form the micellar structure. Then we also perform the differential scanning calorimetry study. So this study is performed to see that what is the interaction. Is it a physical interaction or some chemical changes are happening? So if the chemical changes are happening, you will be able to see that. So when we are also how the entrapment is happening. Now when basically we take, let's say that if it is a curcumin loaded PEG-PLA, we will take the DSCF free curcumin PEG-PLA and then curcumin PEG-PLA micelles and also the physical mixture to find out that whether we could see the physical mixture, we could see both the peaks present, and in the micellar form, we will see the drug which is entrapped inside will not show the peaks there. Then another study that we also perform is the drug release study. And also, as I said, that the advantage of nanomedicine is to sustain the release of the drug, which is very important, because if majorly these anti-cancer drugs are highly toxic, so we can control the release of the drug. That will be great, that we can eliminate or we can minimize the toxicity. So this we also performed that. We found that this polymeric system sustains the dosage, sustains the release of the drug. Now coming to the cell studies, we perform it with the anti-cancers with the cancer cell line. So murine melanoma cells are very common model to test the efficacy of any formulations, and we found it that curcumin has its own fluorescence. So we don't need to tag the nanoparticles with any other dye in that regard. So what we do basically, 1 hour, we perform the 1 hour and 4 hour study, and then we see that in like when we keep it for longer time, the higher penetration of the drug is happening. So what that means is that this higher penetration is due to the enhanced internalization of the nanoparticles through the endocytosis process. And so it's a time-dependent phenomena. So we also prove that by the by flow cytometry analysis. Now here we use another cell line, which is MDA-MB231, that is triple negative breast cancer cell line. So triple negative breast cancer is basically the aggressive metastatic form of breast cancer, which usually affects the young women population before 40. It actually affects, and it is very difficult to diagnose these triple negative subtypes of breast cancer because it has negative expression for estrogen, progesterone, and also the HER2, like epidermal growth factor receptor. So these three expressions, it's not there. So if the diagnosis is done for, basically the breast cancer diagnosis depends on all these three upregulations of all these three markers, but which are not there in for MDA-MB231. So the diagnosis is challenging, and whenever the diagnosis happens, then it has a high effect of metastasis. So it actually goes to lymph node or goes to the other areas, and then so then the treatment becomes more difficult. So now for this, we found that this formulation actually is effective to kill that and actually get internalized by this to this MDA-MB231 cell lines. We also perform the in vitro cytotoxicity. So in vitro cytotoxicity, we take these two cell lines like murine melanoma, which is a mouse cell, and also the basic MDA-MB231, which is a human triple negative breast cancer cells. And we found that in both the cases, this is basically the formulation is very effectively killing the cancer cells. But if you can see that if you see that only the 24 hours time points, you will see that this free curcumin is which is assigned by the blue bar. It's not so effective. If you think about, see that highest concentration, which is 50, this actually, it is like free curcumin is more effective. But if we see here in MDA-MB231, this is basically more effective. So it usually it happens like how the diffusion of the drug is happening, but and also the effectivity of the drug, but it shows that the curcumin is more effective for that compared to the nanomicelles. But usually we don't see that kind of phenomena when it comes to basically in the in vivo models, where the nanoparticles are always effective. So another, as I said, that there is an active targeting strategy. So we also explored the active targeting strategy using the transferrin as the tumor homing ligand. So now what basically is done for this, we used here this PEG-PLA, and we did the thin film hydration as we did before, and after that we added the transferrin labeled curcumin. So in order to do that, and as I said that the transferrin receptors are highly overexpressed, and they actually helps the nano formulation to get internalized. So now we do the transferrin modification into the PEG-PLA copolymer, and definitely we characterize and then for the drug loading, and then we perform the cell-based assays, and we also did another assay where we used a 3-dimensional cell culture system. So what basically how we use the transferrin is it involves the conjugation, because as I said that transferrin is a protein. Now there is no way to anchor that in the micelles, polymeric micelles made out of PEG-PLA. Now in order to put that, we have to make an amphiphilic polymer which will have the transferrin on the surface. So how to prepare that? So we prepared it following this scheme where we used the NH2 PEG-OH, which is amine functionalized PEG, and then we reacted it with the poly-DL lactide. Now that what we found found here is that it is forming the NH2 PEG-PLA, of course, because the polymerization of the lactic acid happens with the OH group. So wherever there are OH group present, it will make the polymerization reaction. So that's called the initiator. So the initiator should have the OH. Now styrus octoate is present at 160 degrees centigrade, will form this, but amine group is unreacted, so it will stay as it is. And then what we use one cross linker, that is MPA. So MPA is a cross linker where it has an active acid group. So if you see here, so this is the active acid group, and this active acid group actually reacts with the amine group by the acid amine coupling reaction. So when the acid amine coupling reaction happens, then this gets conjugated. So we get to get this one, where this basically, this is known as maleimide. So this maleimide is something that this maleimide reacts with the sulfhydryl group via the click reaction. The click reaction means that it can happen in the room temperature. So no need to have any sophisticated, any high temperature or anything, because you already know that all the conjugations that involves in the nanoparticle system, we cannot use very high temperature for any of it. So it always has to be done in the room temperature. So then when we use this, we form the maleimide terminated MPEG-PLA, and then the next step that we did is we used the transferrin and we put the Trout's reagent to react with it. So what is the Trout's reagent? This Trout's reagent will actually add the sulfhydryl group present, because this amine group has, this transferrin has so many, it is actually 77 kilodalton protein. So it has so many hanging amino acid chains. And then whenever there are some cysteine groups and or some other groups present, that forms this, react with the Trout's reagent and will form this terminal SH, which react with the maleimide group to form the transferrin MPEG-PLA polymer. Now how we have to prepare? We have to take this MPEG-PLA from these micelles, and also we have to take the transferrin MPEG-PLA, and then we can make the mixed micellar system, and which will have the transferrin on the surface. So that's how we prepared that. And then we characterized for the drug loading and all other encapsulation efficiency, particle size, and all that other characterization parameters. So here you can see that the particle size increases a little bit, and PDI is also around 0.2, which is good. And then zeta potential also, you for the it was -8, but it actually increased to -21, and because of the presence of transferrin. It's a big molecule, and of course we don't do that modification with high amount of transferrins. Usually if we keep the 2% transferrin on the surface, that's enough to give the sufficient tumor targeting. We also perform the cellular uptake, and we also perform the cellular uptake for 2 different cells. This is cervical cancer cells, human cervical cancer cells, HeLa, and we also use the HED2, which is the liver cancer cell. As I already told you that the transferrin is overexpressed in liver cancer, so we used this liver cancer cell for that. And we also, whenever we do the cellular uptake, we did do with the confocal microscope and also with the flow cytometric analysis. Here we also introduce another thing, which is the NIH33, which is the normal fibroblast cells, and we want to show that there is nothing, no much uptake of that MPEG-PLA transferrin modified from micelles in the normal cells. So if you can see here, you can see some of these green fluorescence here, which is after 4 hours with the transferrin curcumin MPEG-PLA micelles, which is transferrin modified, curcumin loaded. Now here another thing that we also do, that we pre-incubate the cells with the free transferrin to show that there is no upregulation, to show that this nano formulation or nanomicelles are getting internalized by the transferrin receptor. So in order to do that, we saturate the receptors with excess transferrin before we treat the cells with the transferrin PEG-PLA micelles, and we see that there is no upregulation, so it's nothing present here. Okay, so that indicates that this formulation is going through the transferrin receptor only. Okay, so that's what we found. And then here you see that no upregulation, like nothing present, not much present here. So why it is so? Because here we are doing it on the normal cells. The normal cells don't have the overexpression of transferrin receptors. So these formulations are not being taken up or not getting accumulated in the transferrin receptor overexpressing cells, like the transferrin receptor overexpressing cells. Now, we also tried to find out that how the internalization is happening. So which kind of endocytotic pathway is getting getting mediated. So we found for that, and for both the cell lines, we found that this is basically the clathrin mediated endocytosis which is happening. And when we add that clathrin inhibitor, clathrin mediated endocytosis inhibitor, which is chlorpromazine, and then we found that the endocytosis is not happening. So in vitro cytotoxicity also performed, and we see that when we have the targeted formulation, then we have the higher cell toxicity and like decreased cell viability. So you can see here the free curcumin, and then you can see the curcumin PEG-PLA, which is not so active, but you can see that our formulation is way active compared to the other two. Even the same thing is happening here as well. So we also performed another study that we have used this spheroids model. What is spheroid? Basically, it is the three-dimensional okay, so we also have the three-dimensional systems, and we also have this kind of we grow the cells in three-dimensional systems, and then we also try to find out the effectivity. Now, the similar way that we find the under the confocal microscopy and try to find out that how the drugs are, how the nanoparticles are getting internalized. And here also one thing that it is always better to grow the cells in this kind of form, because the monolayers are not the true representative of what is going on in the in vivo conditions. And there also we try to do the study with the apoptosis study to find out that how the cells are actually expressing the apoptotic markers. As I said, that the cancer cells don't want to upregulate any apoptosis markers, so everything is so suppressed. But we could see that with the anti-cancer drug treatment, that this is actually allowing the cells to go to the path of apoptosis. Now, this is the first indicator that we determine by the flow cytometric study using the phosphatidylserine FITC labeled phosphatidylserine marker. We also performed another study to conjugate the cholesterol at the end to find out that if we can increase the efficacy of this system. And for that, you can see that after preparing the PEG-PLA-OH, which I already showed you before, we also tagged that with the cholesterol. So we use the cholesterol chloroformate and we prepared this PEG-PLA cholesterol, and then that actually self-assembles in a much better way. And we find that this system is also effective compared to the PEG-PLA. So if this is the PEG-PLA and this one is actually helping to decrease the critical micelle concentrations. So followed by, we did also the series of studies, the similar way of the cell cytotoxicity study, and we moved to the in vivo studies also. So to find out the tumor volume reduction, and for that we go to the mice. We take the mice and then we induce the tumor, and then we see that, to observe the tumors for 21 days to find out that how the tumor growth has suppressed. Now you can see here, this is one representative. You can see this red signal, which should be the ultimate, like the maximum signal. So you are getting the maximum, we are getting the maximum signal in control over the day of 21, but which is getting highly suppressed or reduced in our formulation treatment. And we also do see the prevention of lung metastasis. And because many of the, like as I said, that in stage 3 or 4, these cancer cells migrate to other organs. So lung metastasis is very common in triple negative breast cancers. And now you can see these two rows that they have the lung metastasis, but in our formulation, there is no lung metastasis. And if we can collect the lungs also, and we can see that these are highly, we can even see the white nodules that are actually the tumor, which has migrated from the region of its generation and went to liver, went to lungs, and but here there is nothing of that sort is visible in our formulation treated mice. So what could be the next generation of nanomedicines? So there will be next generation nanomedicines. There will be a lot of it: photodynamic therapy, photothermal therapy, then combination therapy, combination photothermal therapy, combined chemophotodynamic therapy. So there are so many other things, but then we don't have much time. And so I will not talk about it. So probably sometimes when we will have some other time, we can definitely discuss some more formulations. And so this brings me to the conclusion. And so it's not done yet. We have still got a lot more to do. And definitely you can see that the patients are dying because of toxicity. Patients are dying because of late diagnosis. And so all these things has to be taken care of. And of course, as a scientist, this is our researcher, I feel like it's not about the destination, it's about the journey, because we have to prepare so many different formulations and then compare that to find out that which one will be really effective in the treatments. So we are not there yet. And with that, I acknowledge my lab members, my research scholars, and for their constant hard work makes this kind of studies done. And so of course the funding agencies are gratefully acknowledged: DST, DBT, ICMR, CSIR, and the BITS Pilani Hyderabad campus for providing all the research facilities and all the instruments in their central analytical labs. So thank you. With this, I conclude my talk, and I'm very open to answer your questions. Thank you.
Thank you, Dr. Swati. Thank you, ma'am, for such a wonderful and informative session. Hope all the participants will benefit through this session. So for all participants, you may ask your question to ma'am through chat box. So ma'am, some questions are there in the chat box. May I read?
Sure.
Okay. So ma'am, first question is, how we visually confirm the reaction of PEG-PLA reaction confirmations?
Actually, visually, you cannot confirm anything. So the literature references says that you need to do it for 24 hours. And after that, you can, dismantle that, because we do it in this reaction tubes, because you have to put the nitrogen atmosphere and then seal it properly, and the toluene will be there and the temperature will be maintained to that high level. And then after that, next day you cool it down, you open it, and then you allow the toluene to evaporate, and then you add water and you add water and of course ether. First you add ether and then it precipitates out. Okay, so you get the white mass after that, and then we dialyze also. And then another way, a great way to confirming it by the gel permeation chromatography. So you can perform the gel permeation chromatography and you can get to see that compared to your PEG or compared to PEG, how much increase in the molecular weight happened.
Okay, thank you, ma'am. Coming to the next question. How to identify appropriate target ligand for triple negative breast cancer?
How to
Identify appropriate target ligand for triple negative breast cancer.
Yeah, okay. So this is not part of my research. So we don't basically don't basically look for the biomarkers. This is, I think the biologists will do it. But it has been found that these three major receptors which are present in other breast cancers are not present in these cancers. So that is what is known. But then other than that, the other markers are of course there. So those markers can be explored. But these three major markers that are specific for these breast cancers are not available.
Okay, thank you, ma'am. So next question is, reduction of size of liposome below 50 nanometer also helpful to prevent opsonization by RES instead pegylation or avoiding use of costly PEG-tagged lipids to increase residence time. So can you please enlighten your opinion on this?
Yeah, if you have a decreased size, definitely reticuloendothelial cells will prefer the bigger size in engulfment, but you cannot be sure that they will be not taken up if the size is small. It will be less, but it won't be it won't give you the benefit that the polyethylene glycol is giving. And polyethylene glycol tagged lipids you are using for liposomes, but you can but that is highly required. Even if, and also another thing that to reduce the size of liposome to less than 50 nanometer will not be an easy job, and so that is it requires so long process optimization. Usually the liposome size is never that small. It's always coming to 80 to 100 nanometer size. If you think about the doxil or lipodox, you see that the particle size is 85 nanometers. So it is not it's not very I will say easy to prepare that small size.
Okay, thank you, ma'am. Next question is paclitaxel used in melanoma cancer model? If yes, what is the dose? Or if no, why it is not used?
Yeah, you can use paclitaxel in melanoma cancer model. And if you are thinking about performing any in vitro study, so we start with the same dose of 100 microgram per ml on cell for the cytotoxic analysis. And yeah, it can be used.
Okay, thank you, ma'am. Next question. Is these nanomedicines applicable in breast cancer or in all types of tumors or in particular type of cancer?
Yeah, so see, the nanomedicines can be used for all types of cancers, but there are some cancers which cannot have that EPR effect association. So it's like prostate cancer. Prostate cancer is so deeply embedded and it's so slow growth that it cannot take much advantage of the nanomedicines. It doesn't take much advantage of the enhanced permeability and retention effect. But it can have the advantage of active targeting, because there are some like one particular receptor which is PSMA, prostate specific membrane antigen, which is found only in prostate cancer. So if you have any active targeting system made with that PSMA receptors, ligands or anti-PSMA receptor antibody, then you can target that there as well.
Okay, thank you, ma'am.
Hello. Hello. 1 minute. So I have one question,
Yes,
madam.
yes.
So my name is Dr. Arindam Maiti, Associate Professor in JISU University. So my question is that one of the important factor for cancer treatment is diagnosis. Now, if we identify early diagnosis, then treatment will be much more easier and it is more curable. Now, what is your opinion, ma'am, regarding to the diagnostics applicable by that nanoparticle your identification systems? Because there are different type of cancer cell and their characteristics is different, and how they are actually identified by that nanoparticle drug delivery systems.
Yeah, so nanoparticular drug delivery systems gives you the advantage of accumulation, right? Eventual accumulation to the tumor tissues. So if we can exploit that, there are different nanotheranostics or nano diagnostic tools which are coming up. So as I said that this photodynamic therapy. So photodynamic therapy, the drug itself actually glows. So
research
their conjugations, like they have the big, I will say that benzene rings in a conjugated form that they emit the lights. So they get excited and they have the emission at the red near infrared. So we can actually see them under. And also there are some stables like carbon dots. So those things are coming that we can diagnose them. But then also specific markers can also be exploited. And nowadays, there is also some of the other things like coming as a freight approach. So recently, I was reading an article that if you have the graphene oxide and carbon dots together, then the fluorescence is suppressed. But when it goes to heterogeneous cancer cells, like the normal cells, cancer cells, then somehow in cancer cells, there are so many other things upregulated. We already know that it's an acidic environment. It is also, there are so many MMPs or so many other things like low oxygen concentrations. So if we have something like that, the bond is breaking in that, and then they are getting liberated out, then the carbon nanodots will give the stable luminescence. So those kind of things can be explored, but as I'm not into the, till now, I'm not into the area of diagnostics yet. So I'm still doing in the medicine, but yeah, these are the approaches that can be definitely followed.
Thank you, ma'am. Thank you for your
Thank
guidance.
you, ma'am. Another question is there. What is the dose of paclitaxel in vivo melanine cancer model?
Dose of paclitaxel in the in vivo cancer model. Yes, so dose of paclitaxel is 10 milligram per kg body weight. I have to double check, but I think, yeah, it is 10 milligram per kg. And for doxorubicin, it's highly potent. So it was 5 milligram per kg body weight. And we have given the intravenous administration. So yeah, that's the dose.
Thank you, ma'am. And participants, if you have any other questions, you may ask. You may unmute and you can ask ma'am. And hope
Yes, since there is no further question, then we can go for conclusion. Swatidi, it was a
Yes, sir.
wonderful presentation, and I'm lucky to have you on the virtual platform at my department. I think all the faculty participants have immensely benefited out of your talk, and I hope to have you in our campus in near future.
Yeah, I also like to come and see, because this is kind of interaction that it is going only one way. I cannot see the other people. I cannot, see them. So yeah, something happened. That's really good. But definitely, I also want to visit once and deliver there.
Right. So with this, in virtual world, this is a small token of love from all of us.
Thank
Stay
you.
happy. Stay happy and healthy, and wish to see you progressing more and more. Thank you, Satidi.
Thank you. Thank you. All the best
Thank you,
to all of
Satidi.
you.
Sati, you are looking great.
Oh,
You're very bright.
thank you. Thank you. Thank
কে
you.
বল-
See
কে
you.
বলছি আমি into the
Into the okay. তোমার টক আছে আমি শুনবো কালকে।
না আমার টক নেই আমরা শুধু এইসব গেস্টদের থেকেই শুনি খুব ভালো
হ্যাঁ,
হয়েছে দারুণ এক্সেলেন্ট হয়েছে অ্যাকচুয়ালি এই ফিল্ডে যারা রিসার্চ করছে আমি দেখলাম প্রথম থেকে শুনলাম মানে একদম ন্যানো পার্টিকেল ডেলিভারি সিস্টেম তার একদম বেসিক থেকে শুরু করে টার্গেটেড ডেলিভারি থেকে শুরু করে এভরিথিং কাভার্ড ইউ হ্যাভ কাভার্ড এ লট অফ থিংস মানে ডেলিভারি সিস্টেম থেকে শুরু করে পলিমার মানে এই যে অ্যাম্পিফিলিক পলিমার আমরা জেনারেলি হাইড্রোফিলিক পলিমার ও লিপোফিলিক পলিমার ও পলিমেরিক মাইসেলি এই ফরমেশন আমার কিছু আছে কোয়ারি সেগুলো আর এখানে করছি না প্ল্যাটফর্মে আমি পরে কন্ট্যাক্ট নিয়ে করে নেবো কারণ কি আমার একজন কাজ করছে এই ফিল্ডে
আচ্ছা
একজন রিসার্চার এই পলিমেরিক ন্যানো পার্টিকেল অ্যান্টি ক্যান্সার ড্রাগের উপরেই এই টপিকের উপরেই করছে
আচ্ছা
তো সেই বিষয়ে কিছু হয়তো ফার্দার কোয়ারি কিছু থাকবে আমার বা আমার স্টুডেন্টের সেইটা নিয়ে পরে আলোচনা করে নেব এত বড় লম্বা টক দেওয়ার পরে আর কিছু করছি না
Good morning.
So here we conclude with all your permission because we are running short of time for the next speaker. It's 11:31. Thank you, Satidi. Thank you.
থ্যাংক ইউ ভেরি মাচ
Thank you. See you.
Thank you, Satidi, for accepting our invitation.
Thank you.